This is Talk Business and Politics with Roby Brock.
State lawmakers will spend the majority of this year looking to reshape the private option and Medicaid before 2017. That's the deal Governor Asa Hutchinson struck with legislators in the recently completed session. Arkansas Democrat-Gazette columnist John Brummett sat down with Representative Charlie Collins of Fayetteville and Senator Jim Hendren of Sulphur Springs to learn what direction they'll be taking their legislative colleagues. John Brummett now joins us in studio. Welcome and thanks for being here.
Always a pleasure.
You sat down a little bit earlier in the week with Senator Hendren, Representative Collins, the co-chairs of this legislative task force on healthcare reform. What is their daunting challenge?
Only the biggest challenge facing the state. That is state government in terms of how we address Medicaid spending and healthcare spending, hospitals in terms of whether they can avoid bankruptcy, health insurance for 250,000 nearly low-income people, and a healthcare exchange in Arkansas, the rates for which, the premiums for which have been held down by the inclusion of this private option. And now we have a task force, and they're going to keep saying in the interview it's about more than the private option, and I'm going to keep taking them back to the private option. This task force must get us somewhere by 2017. There's a cliff there, and this task force was going to either continue, change, or discontinue this major policy.
All right, let's listen into that interview.
Okay, Senator Hendren, I did you the kind favor in the paper this morning of telling you what the first question was going to be, and I know you've done your homework and you're ready for it. What is it about the private option, which is coming in under estimates, taking care of 250,000 people, helping the state budget, helping hospitals? What is it about it that is broken and needs fixing in the context of this task force that you co-chair?
Well, I do appreciate the advance notice on the question. So I will tell you that one of the first directions I gave to our task force, or pleas that I made with them, is to avoid the tendency to continue to relitigate the private option, because the task we have is so challenging that being drawn back into a debate that has already been settled, at least for the next year and a half, is not productive. So we have avoided that, but because you want the question answered.
I hate that I asked an unproductive question. But
well, I wouldn't say it's unproductive, but I would tell you that it's not productive for what we're trying to solve, which is health care in general in Arkansas. The concerns that people, including myself, had about the private option were not based on how it would perform. There's no question. I didn't dispute the fact, and I don't think any reasonable person disputed the fact that putting $1 billion of money into any industry is going to produce results. And it did. It helped hospitals. It gave people insurance coverage that didn't have it. But I think what we also have to realize that the concern was, how do we sustain it and how do we afford it, particularly given the fact that the entire healthcare budget of Arkansas is the fastest growing segment of our budget. It's pushing out every other program. It's growing twice as fast as our other areas. And now we're going to increase it by 20%. So we're going to accelerate this gobbling up of our budget by uncontrolled medical costs. So the fact that I don't disagree and I don't dispute the fact that we're spending $100 million a month paying for insurance premiums. But what I think we still have to look at is that the best way to address the need of uncompensated care, of making sure people get the health care that they need. They were getting health care before the private option. As you know, we're spending about $300 or $400 million a year on uncompensated care. So are we really doing a better service by spending $100 million a month on insurance premiums? Those concerns have not changed. So while I think that we can continue to fight that fight, what we're looking at is the entire scope of the health care program. Okay. If we don't change it, it's going to devour our budget.
Okay, Representative Collins, I know that's true. I know you're talking about more than the private option, but I'm going to ask at least one more, if not 3 or 4 more questions. Sure. about the private option. You voted for the thing in the House from the beginning, and through all of Davy Carter's maneuverings, I think you probably voted for it the first 2 years 20-25 times.
Right.
And then you voted for it this time, of course. Yes. But now, as I understand your position, it's that something's different. What's different now? You knew a state share, a state match was coming. Is there something different now from the circumstances at which you voted for it repeatedly and spoke for it quite eloquently, I would say?
No, and I'm still for what we're doing. So to the point that Jim just made, it is now May of 2015. And in May of 2015, as we look forward, what do the opportunities look like? What is the landscape that's different? And how can we do even more to achieve what I would submit to you are the key principles, at least that I was acting on, as we move forward with the private option. Principles like, let's use market forces. Principles like, let's move toward personal responsibility and accountability. Principles like, how can we make healthcare overall more cost effective? What are some of the changes now versus where we've been in the past? Well, there's an animal that's called a 1332 waiver that has not existed, as far as I know, in the history of time until 2017. Nobody's ever even filled out the application for a 1332 waiver that I'm aware of. So one of the things that's different, and different in a significant way, is the opportunity to have a very innovative and different system. That's one example. I think there are others. How do we build on where we've been, take the innovation we've already brought forward, and add to it to do the things that are going to be as fiscally responsible and market-oriented as we can?
I want to get to the 1332 waiver. I don't think people know that the Affordable Care Act itself permits states to seek to do their exchanges entirely differently, and that's a big part of what we're trying to do. I just want to throw out for both of you, if the private option, forgive me, one more on the private option itself, is working as you expected with some demonstrated success, and you're looking at all of the human services, Medicaid, health care budget, what would be wrong with your focus being finding savings outside the private option and applying those to the match? Is that a possibility as to what the eventual outcome will be?
I think one of the things I also cautioned the task force was trying to determine the outcome before we fully get the data. And one of the biggest lessons I've learned in Little Rock is we make decisions on bad data. We've done that time and time again, and the easy answer is let's just throw more money at it and that ought to fix it. And in some cases it does. But what you said is a possibility. I don't think it's a very likely possibility. I think that until we find out what the potential savings are on the current Medicaid program, it's hard to figure out what we might do with those savings.
So where are you starting? Where are y'all starting, either of you? You're going to start with what we're spending altogether on health care services in Arkansas, including developmentally disabled, mental health, a nursing home, elder care. You're going to put all that out and see, is that first thing, to figure out how much we're spending and how can we address spending less?
I think, yes, figuring out what are we spending and how are we spending it. How can we get aligned about what numbers really are? Let's take something like uncompensated care, just as one set of numbers. How exactly do you count that? How exactly do you count what money's being reimbursed in uncompensated care? How do you count money that we used to get from source A for uncompensated care in the year 2012, but because laws are changing and things are changing, in the year 2018, that reimbursement for uncompensated care won't happen. Just gathering those numbers and getting them laid out in a way where everybody can see and get a clear picture takes a lot of work and effort. We spent several hours in one of our healthcare task force meetings trying to begin to understand how do we count uncompensated care, how do we look at reimbursement for uncompensated care, what exactly does it cover, and that process has really opened the door and a lot of eyes to how complicated even just one simple subject like that really is.
Okay, I don't want to bog down, but
the process I laid out, John, was we're going to spend the next 4 or 5 months figuring out the program we have.
I understand that. But our governor and your uncle and our governor, Asa Hutchinson, I think what he said was, let's look at another way to cover these people who are now covered. I think our objective on the strict matter of the private option is that they will continue to have some form of insurance.
Let me clarify something, because
is that not accurate?
It's not completely accurate.
So it's possibly they're going to be thrown off.
No, if you look at the bill, because this was a discussion we had in the language of the bill, is the goal to provide health care services or health care coverage? Because one of the initial drafts said what you just said, we're going to continue to provide coverage. But we changed that because that's not necessarily what we're assuring.
You all are making a case here for uncompensated care, aren't you? Let's go back to absorbing.
I told the hospitals it is not fair for us as a nation to require them to cover a service and then not pay for it. I certainly agree with that concept, and that's one of the things we'll establish, is certain principles we can all agree on.
But the commitment is not necessarily to insurance, it's to continued health care.
Health services, which we had before the private option. You know, if you showed up at an emergency room, the federal law has not changed. You're going to provide services to those people. But what I ask people who think that insurance is the answer, is there any evidence that shows that improves health care? We're spending $100 million.
It certainly improves, doesn't it, premiums for the rest of us, at least people buying on the Arkansas Healthcare Exchange. By pouring that number of people in, that's helping everybody, right?
Artificial manipulation of the market by $1 billion of tax money. That's to me not a benefit, that's a consequence. I
really?
mean, absolutely. I mean,
that's a bad use of available federal money in Arkansas to insure these people and hold everybody's rates down artificially.
I think anytime you begin to manipulate the market, you're asking for trouble. That's not how our society, and that's not how you generate productive behavior. It has to be based on market-driven forces, and throwing $1 billion into a program saying that, well, putting all these healthy people in the program is going to drive down the rates for everybody else, that's not how the market-driven economy works.
Charlie, are you with him on that?
Yeah, I think what we're going to have, the task force is made up of people with different points of view. And in order to get people with different points of view to come to some type of a consensus around something, we have to agree on one of your favorite subjects, arithmetic. And exactly what are the numbers, how do they add up, and what are the options? And when you can see all those things clearly, then the choices become more clear that you can make. So the thing that I think is tough to do right here and in this discussion is to suggest, boy, uncompensated care is going to cost the Arkansas taxpayer X dollars, because it depends on which year you're talking about, it depends on the program you've got, and until we get all those numbers laid out in a way that we've all agreed makes sense, we can't answer the questions that you're asking. But will the program be more market-oriented than where we are today? Do we move it forward in that degree? Yes.
We're getting to that.
Yes.
But you are not, when we started this 10 or 12 minutes ago, I was thinking something different from what I'm thinking now. There is a legitimate, and I know you don't want to discuss it, but there is a legitimate possibility that you guys are not just rhetorically, but seriously looking at no longer doing insurance coverage for the Medicaid expansion population. That is on the table.
Commitment to the task force is to look at everything. So it's on the table for me, and I think it's part of the charge of the legislation is to look at everything.
So you're not sure it's the success you said it was?
I believe that it is. I have a hard time. I asked the question at the beginning of the private option debate, and again, we continue to get drawn back into that.
Well, I know, but
because
you understand
it is,
that's a major issue.
Well, I know, but it is 20% of the budget that we're talking about here. But I think there are more efficient ways to accomplish what we need to accomplish of taking care of that population. That's a healthy working age population that the easy thing to do is to give 250,000 people insurance. But again, I ask you, when we spent $100 million last month, and I asked UAMS, I said, do you guys have any idea how many of those people actually filed claims on that $100 million premium that we paid? Nobody knows. And I've begun to ask the questions of the insurance companies, and we're going to find that information out, because the short answer to your question is I don't know until we get the data. But intuitively, I think there are more efficient ways than just saying we're going to throw insurance policies out to 250,000 people that aren't traditionally absorbing a lot of healthcare costs.
I think the difference, John, this time versus where we were before is where we were before we really had, everybody thought kind of two choices. Either do A or do B based on what the Supreme Court laid out. And then there was a third option created, and that option is now known as the private option. It dealt with a limited number of people, did not deal with the whole Medicaid program, and the choice was either to do that or not do that. Now where we are is kind of going back to ground zero and more zero-basing a look at the entire Medicaid program, including the private option part. And nobody is trying to predict the answer until we get there.
Okay.
Yeah.
Okay. I understand that. And I regret that we've bogged down on this, but I think it's probably the thing of greatest interest to a lot of people and a lot of hospitals. And in that regard, before we finish, and this is still going to tie into the private option, but a big part of this is that in 2017, under Obamacare's law, states may design their own exchanges to cover the same number of people, but with their own processes. And you earlier referred to that, Charlie, as an element of this, and it's going to be more market-oriented.
Yes.
Now, I think I've talked enough to David Sanders. I think I know what that means, and you can discuss that. But two elements of that might be and then you can go anywhere from after that, some sort of work encouragement requirement, work incentive for Medicaid recipients, and then asking the federal government to give us a Paul Ryan style block grant, and we'll make do with a block amount of money. Is that what you're talking about?
To me, all those things are on the table. I like the idea of block grants conceptually. I like the idea of being able to say to the federal government, here's an Arkansas way to deliver healthcare quality, healthcare access, and affordability, and it's better than Obamacare, so we want an exemption from Obamacare so we can do it another way. I like the idea of encouraging healthy behavior so that people make choices that are incentive-driven and consequence-driven. So if you behave in a certain way, that's going to have a lower overall cost, and you're going to get benefits from that. How exactly we build that into the system, I don't know. And then there's another thing, John, which is anything we do today that suggests to somebody, if you go and get a job, because you're now making more money than some certain threshold, you're going to lose more than you gain. To me, those are perverse incentives. And our existing systems are laced through and through with those things. So consumerism, letting people make choices, letting people connect the dots between, I could pay $100 for this service at provider A, or I could buy the same service for $75 at provider B, and I care about that now because I get some extra benefit for making a good choice. To me, those are market forces. How do we get that built in? I don't know all the answers yet, but that's where I'm headed.
Senator, on the block grant and market reforms in general.
I think a block grant is very appealing to me. I think that we need some flexibility to determine what works best for Arkansas. We need a system that, rather than making people have a disincentive to get a job that provides benefits, provides an incentive for them to get a job where they can get benefits. Unfortunately, part of the unintended consequence of some of the things we've done, people are leaving private insurance policies that are subsidized tremendously by the private sector for other for entitlements that were given away at the expense of the taxpayer. All those things have to change. All those things have to be.
You mean people are leaving a job in which they might buy insurance through the exchange to go on the private option, or to stay home? Is that empirical data? You got people who are actually doing that?
I do. I know people who have left a job where they were paying $30 or $40 a month for insurance to go get insurance that the company was subsidizing this other 80% of it or 90% of it, because they could get a better deal where the taxpayers funded 100% of it. Those are the sort of situations that we have to think before we start doing these things.
We're about out of time, but how hard are y'all intending to work? Because everything that we've talked about here is complex, and it's emotional, and it affects a lot of people. And you've got to make a report by the end of this year so we can start working on our waivers to be effective in 2017. Am I right about that? I mean, what's your work schedule going to be this year? Are you just moving to Little Rock and dealing with this every day, essentially?
This week.
Well, I mean, this is. We're having a discussion about something that is massive.
John, if you go back and look at the first time I talked about the private option, one of the things I said was, Arkansas is on a path to help lead the country out of the health care challenge that we've got.
Well,
Obamacare didn't do it.
Well, I know the private option's doing it, but
That's
now we're going to abandon that.
We're not going to abandon it. We're going to create. We're going to create an even better market-oriented, market-driven scenario for health care, which I believe other states will want to adapt.
We're going to do something even more innovative,
even
more cost-effective, and even better for our budget and our people and our hospitals.
That's the goal.
That's the goal. And how hard are we going to work to do it?
The biggest legislative challenge I've ever seen the legislature try to take on. You're right, it affects literally hundreds of thousands of people, and it affects our state budget. It affects indirectly K through 12, higher ed, prisons. It affects everything. And we have a tight time frame. People came and asked me to move the time frame up on the bill, and I said, we're going to be hard-pressed to do it. So the short answer to your question is we're going to work hard. We're going to meet a lot this summer, and especially once we get the report back in the fall. We're going to have to. I mean, it's too important not to. And all of us have busy lives, and we've got some great legislators on the panel. But I expect we'll be down here a lot because we cannot afford to not do a good job on this.
It's also not going to be like a one-shot deal where, there's some date like October 15th or December 31st where there's going to be a magic answer and it's got everything wrapped up in a bow. There's going to be a step 1, There's going to be a step 2. There are going to be some things that are just too hard to figure out in a certain amount of time, but we'll keep working on those so that I would imagine some things are going to happen in phases.
So there's not going to be a hard deadline of the end of this year to begin designing the waiver for the next year.
Well,
it's going to be more fluid than that.
If we decide to go for a 1332 waiver, which I don't want to predict that we're going to do that, I've certainly got a lot of interest in it. If we're going to have that go into effect in January of 17, you can back up the dates. If you want someone to start applying for that insurance, that means you need to have the thing done by October of 16. If you're going to have a waiver approved by October of 16, you basically need to get it to the feds a year in advance based on what the timeline looks like. So already we're talking about this fall needing to get some things together if we wanted to have a waiver like that ready for January of 17.
So I thought you said we're not going to have to work against a hard deadline, but you are.
The deadlines.
No, what I'm
Well, I
saying
mean,
is,
if we do.
Yeah, John, I agree we're working against hard deadlines. My point is we're not going to figure out absolutely everything
we're
by
out of time.
October
Last
or
word,
December.
Senator?
No, the time frame is tight. The deadline at the end of the year was intentional because it does take a year to go through the waiver process. If we don't do something in that time frame, 14 months from now,
Right.
cancellation notices go out.
Well, good luck to you both, and may you do the right thing.
Thank you.
All right.
All right, John Brummett's with us here in studio. He obviously conducted that interview. So kind of what were your big takeaways from the interview?
One, Jim Hendren, the Senate chairman and Governor Hutchinson's nephew, did not want to talk specifically about the private option. He wanted to couch the thing in terms of broad health care policy. I wouldn't let him, and we ended up talking about the private option. Two, he stakes out a position that indicates that he is conceivably willing to discontinue accepting federal funding in 2017, which I'm sure sends shockwaves through the healthcare community of the state, and is either because he's naturally there or because he sees a tactical need, he is defining the right wing in terms of the parameters for the discussion as we go forward. The idea that we would turn down this money and go back to a system of uncompensated care at hospitals is a remarkable thing, in my view, to even put out there. But he put it out there at this point.
All right. He's John Brummett. There's more to this interview with Representative Collins and Senator Hendren, which you can find right now on our website at talkbusiness.net. Now, John Brummett's got more to say after this word from our sponsors here. The debate over the death penalty, it was a point of discussion in the last legislative session, primarily finding a way to obtain the drugs necessary for lethal injection. John Brummett's written a feature story for us on the subject, which we'll explore right after this.